Welcome. Thanks for being here at a bit late hour in the day. I see some very familiar faces, and it's always nice to see friends. So today's talk is really centered around metabolism and how we can help with the metabolic problems that we see in this country, i.e. Obesity, excess weight, and its metabolic derangements that are quite well known. So for the next half hour or so, I'll try and cover at least three major areas. We'll talk about the concept of metabolism and what it really means. Then we'll discuss the issue, the syndrome, the entity of metabolic syndrome or metabolic disorders. And then we'll focus on the various operations that we can offer patients to improve their weight issue and also improve their metabolic problems. So if you ask a room full of physicians or healthcare providers what metabolism means, you're most likely going to get as many answers as the number of people there. It's a big word, and it means really the sum total of all the reactions, chemical and physical reactions that go on every day within a living organism. It covers a variety of different sub-entities, but this would be an example of some of the metabolic pathways that exist in our human system. To a great extent, when we talk about metabolism, we're dealing with how an organism handles energy, food, and how that gets broken down via enzymes or hormones, and we end up with fuel for cells, fuel for growth, and at some point there will be the process of breaking down material or building, so the two components of metabolism being anabolism or catabolism. And we predominantly use the energy that we obtain from fuel for what's called the resting metabolic process or resting metabolic rate. That consumes about 65% of the energy we need. What that is just all the various components of a living organism without doing much, sort of to keep the lights on. The remainder of the energy we need is to perform physical activities, or there'd be some generation of energy while we handle food, the thermal aspect of feeding. And then there's a genetic component to all of this. So this is sort of a broad view of metabolism from a distance. But in an ideal state, all of us aim for this, wherein your calories that we consume during a 24-hour period match the needs. And so there's no over supply, and we have a homeostatic state, a state of balance. But sometimes that balance is broken, and that's what we're here to talk about. Most common cause is human behavior, and we live in a society where food is processed, it's calorie dense, and it's very easy to pack 2,000 calories in one meal. And we had a talk earlier where we talked about how much energy one has to burn or consume to offset that one meal. It's roughly a half a marathon a day for that one meal, and most of us don't do that. So here we are with a very easy explanation for some of the metabolic derangements or the oversupply of energy that we see in our society. But that's obviously very simplistic, because we know a lot of individuals out there who do not consume 2,000 to 5,000 calories a day. They've had a childhood history, they've had a familial history, and so there is a genetic component, a predisposition to having a quote-unquote slow metabolism. They don't handle energy, and they're not as efficient, or some would argue their digestive system is extremely efficient and they absorb most of what they consume. So there definitely genetic variations that explain some of the findings out there. Then we have some of the very physiologic things that occur in our human lifespan. As we age, that big 65% slice of the pie you saw, the basal metabolic rate, our BMR really drops down significantly. And so we don't require so much energy to keep the lights on. And that means that we either have to exercise more or consume less. And that adjustment, if it doesn't occur, obviously you see weight gain as age goes up. Something as natural as getting pregnant induces weight gain, and if that weight gain is not offset by weight loss afterwards, obviously that adds to the problem. Disease conditions. Cushing's syndrome is one. There are many conditions in which our hormones are out of balance, low thyroid states. And so in these conditions, again, the metabolic rate is slower, or the hormones or medications that doctors pour at us end up causing weight gain. So there are a number of different aspects to this derangement in the metabolic homeostasis, and it's not always just behavior. So as a next step, let's try to understand what happens when we consume too much or when we end up with a surplus of energy. What ends up happening is our body stores that energy in the form of fat within various organs in the body and externally as well. And the problem with excessive storage of fat is you end up with a lot of chemical products as a result, fatty acids and a lot of metabolites down the road end up with what we consider to be a very pro-inflammatory state. Your body is in a state of inflammation. All the markers of inflammation tend to go up once you reach that state. And they result in a lot of damage to our various organs. And that entire entity is what we consider to be a metabolic syndrome. Now, again, sort of a vague term out there, what does this metabolic syndrome mean? Well, at the core of it, at the base of it, one of the most important elements of metabolic syndrome is the fact that our ability to handle blood sugar via insulin, a very important hormone that we all possess, is compromised. This is how normally body handles blood sugar, right? You consume food, whether it's from carbohydrates or not, and glucose or sugar is one of the end products, and insulin helps via various cell receptors. It helps the sugar to enter the blood and enter the cells and get utilized. But when cells are laden with fat, they tend to be resistant to that action of insulin. And so that insulin resistance is one of the first triggers which makes our body work harder, produce more insulin coming from the pancreatic gland. And that excessive insulin is trying to overcome this resistance. And we end up with conditions of insulin resistance, prediabetes, diabetes, and the whole spectrum of excess blood sugar. This extra insulin that your body is making can have its own side effects other than not being able to keep up with the demand of handling sugar. It then can also stimulate our other organs, such as in females, the reproductive system gets affected, and we get a condition called polycystic ovarian disease, where the ovaries start making androgenic hormones, male hormones, and it has its own set of sequelae. The fat that's laden in various organs can itself cause damage locally within the organ. Look at the liver, for example. Common entity we all have heard of is fatty liver. It's actually the most common, it's the number one cause of liver failure in this country. And what happens is, just like other damaging entities in the past we've known about hepatitis or alcohol, this is no different. Fat within the hepatocytes or within the cells of the liver can cause pretty much the same picture as alcohol or viruses do. You first get fatty liver, then you get inflammation from that, and finally you get cirrhosis or scarring. So the end result being liver failure. Excess fat, of course, can also cause atherosclerotic disease and heart disease and high blood pressure and variety of coronary artery disease conditions that ensue. It can cause increased risk of stroke. Even things that are not very intuitively linked to obesity or excess weight, like cancer. Because of its pro-inflammatory state and various other inflammatory mediators that cells start producing as a result of excess weight, we have an increased incidence of cancer in individuals who are heavier. And it's not well understood, but it is supposed to be mediated via various various chemicals like tumor necrotic factor and various other chemicals we normally possess that fight infection, they fight early cancers, and they become inefficient. So what happens with all these various disease conditions? It translates into an increased mortality. And it's a linear relationship. As the weight increases, our risk of death goes up 2 to 5-fold. So it's a fairly significant blow, and one that we always emphasize is not just the quality of life we are concerned about, it's the length of life and how long we're going to live. So how big is this problem in this country? It's really very significant. If you go back to the early 90s and follow every year the map of the U.S. based on the prevalence of obesity, you'll see a fairly impressive increase in the prevalence every year. Different colors, new colors, indicate a higher percentage of people who are obese. So we began with less than 10%, and we are now at a point where we're looking at majority of states are over 25% severely obese. That's just another way of looking at the same problem. And we obviously have a way of classifying excess weight into, early stages all the way up to more severe states. And we use body mass index. We don't need to go into details. Your weight by your height in squares. And all these categories have increased significantly over the last 2 decades. So with that, on the healthcare side, we are seeing the same type of a trend, increased admissions and discharges for diabetes. And so going back to metabolic syndrome, we talked about how insulin resistance in diabetes is at its core. The other components of metabolic syndrome are high blood pressure and central obesity, obviously, and obstructive sleep apnea. So we have this clinical entity that's affecting nearly 50 million individuals in this country, and about half of them, or a little less than half of them, directly have excess weight as their cause for their metabolic syndrome. So what can we do to help these individuals? What are the weight loss solutions? Diet, exercise, and now surgery. Traditionally, we've always offered weight loss diets, and obviously it still continues to be our first modality. The problem with dieting is this: our body is very smart. When we diet, it thinks we are starving, because we are. And so evolution has brought so many pathways within our metabolism that counters that state by increasing our hunger hormones. On the left, you'll see ghrelin, which is one of the main hormones that controls our appetite. And if you see the black line, that is the baseline. And as the line moves to the right, that is the amount of appetite hormone you'll see in the bloodstream in relationship to a meal. So you start off with a level of 100 and some. Following a meal, within an hour, it's at its lowest. The hunger's gone. And then it gradually comes back to a state where you feel hungry again. But if you're dieting, you already have an increased hunger. The other two lines you see are people who've been on a diet for 10 weeks or 60 weeks. And at every point in this meal event, they happen to have an increased level of hunger. So that doesn't help. And that explains to a great extent why dieting doesn't work, because it's hard to be hungry and not eat. You may be successful for a period, but over a long period of time, it's not a very sustainable state. And on the right, you see the sort of the opposite. Another hormone that we will talk about in a little bit is called PeptideYY. And this hormone makes us satisfied with meals. It's the opposite of hunger. And you see the exact opposite effect. So less PeptideYY, more desire for food, and we start off with a disadvantage if we are dieting. How about exercise? Well, individuals who are heavy have problems with joints, pain, inability to really get out there and exercise and to burn those calories. And also, again, as a long-term lifestyle issue, exercise brings with it increased hunger, and again, that tends to counter the effect. So, yes, it's important, but when you have to lose over 100 pounds, it tends not to be effective. Which brings us to metabolic surgery. Now, to understand what bariatric surgery in 2015 means and how far we've come, we've got to go back to the beginning, 1960s. Ed Mason from Midwest, a very brilliant surgeon, he observed that when we did surgery on patients who needed part of their stomach removed, those patients lost weight. Simple observation. And so he came up with the concept of gastric bypass, or Roux-en-Y gastric bypass. It's a procedure that has stood the test of time. So by all definitions, it's a very successful operation. And the way it's done, and I just showed you a picture of another California surgeon who years later was the first to do it laparoscopically through this very small incisions. And so that's what we are seeing here. We make very small incisions so the pain is minimized and the complications from surgical incisions minimized. And the concept is, using the native stomach, we staple and separate the top of the stomach from the remainder, and then we bring the small intestines and make a connection to that new stomach, this being the new gastric pouch or the new reservoir for food. The remainder of the stomach is a healthy living organ. It never receives food anymore, but it does all the other functions. And so by this new anatomy, Ed Mason was able to divert food away from our stomach and parts of the digestive system, the duodenum and proximal jejunum. And so what happens here? Well, we eat less food because we have a smaller stomach. We also don't end up absorbing everything we eat because some of the food likes to travel through the entire length of the gut, and we don't allow that. So we interfere with some absorption. And we really didn't know anything beyond that back in the day. In the 1960s, when this operation was designed, it was thought to be essentially a mechanical restriction of the food intake and some interference with absorption. Now, fast forward many decades, we now have a better understanding what that operation did or does. Not only it does those two things of restriction and malabsorption, it also changes a variety of hormones that our digestive system normally makes. And that's called the metabolic effect of these procedures. It wasn't known then, it was totally unintentional, but the observation was these patients really responded quickly, very, very quickly, immediately, within a day or two even, they improved their diabetes and their health, and it wasn't explained by weight loss, obviously. And so that was the beginning of our understanding of ghrelin, appetite hormone, and the other hormones we just touched on. And obviously that was the beginning of our understanding of how these operations are actually metabolic operations. And by that we mean manipulating a normal system, in this case digestive system, in order to bring a response. The response here is changes in the gut hormones, for the end result or the potential health gain, in this case, please come in, being improvement of the metabolic derangements. So that's the whole idea of a metabolic surgery. We operate on a system, in this case digestive system, and we bring about all these secondary benefits to diabetes, to energy consumption, and so on. Now, in 2015, we have another operation that is called vertical sleeve gastrectomy. And the way this procedure works is a little bit different, although the net result is very similar. It's different because the procedure doesn't involve any manipulation of the small bowel. It's mostly focused on the stomach itself. And it involves removal of about 80% of the stomach, as opposed to just simply dividing and partitioning the stomach. So here we are interested in removing about 80%, leaving about 20% behind. And we really end there. We don't do anything else. Just a quick video for those of you who don't mind seeing actual operations. The way we do this operation, we obviously have to detach the blood supply of the curvy part of the stomach so that we can then remove that part of the stomach. We use sophisticated instruments that allow us to cut and coagulate, or I should say coagulate and cut blood supply without having to have our hands in there or perform any kind of a tying around the vessels. And then we use this device called a GI stapler to divide the stomach and seal the stomach where it divides it or it cuts it. And finally, make some adjustments to place stitches to hold the stomach in place. And that's a little biologic solution to help hemostasis so we don't end up with any kind of a oozing afterwards. So you just saw a stomach being reduced in size, but just like gastric bypass, there's more to this operation than just simply downsizing the capacity of the stomach. So let's talk about that. So ghrelin is an appetite hormone that is made by our stomach, and it was fairly recently discovered, about 10 years ago or so, or a little over 10 years ago. And what this is nothing but a peptide, 28 amino acids. It's made by the cells that reside in the fundus of the stomach. And when we bypass that part, or when we remove that part of the stomach, in the two operations we just saw, we get a significant drop in this hormone in our bloodstream, and this effect lasts for life. These are patients 3 years after gastric bypass. Compared to normal, that's where their appetite hormone resides. Same thing you're seeing in a sleeve patient. 6 months later, the levels are significantly lowered compared to baseline. And that makes sense because the cells have gone. They're either bypassed or completely removed. PeptideYY, also a short peptide made by the lower part of the digestive system. And its function is to be the opposite. It gives us the sense of satiety. We eat a food, we eat a meal, and we feel satisfied. And partly that's from this hormone. And because the way the food is delivered to the lower part of the gut is changed, in gastric bypass, we've definitely mechanically changed the way food gets to the small bowel. And in sleeve gastrectomy, the way the stomach holds on to the food is changed, and it empties itself a lot faster. We get essentially the same effect with both of these operations. Increased levels of satisfaction or satiety after eating food. So what's happening here is we've given small stomachs to patients in both of these operations, but we've also given them these tremendously strong tools of lower appetite and higher satisfaction with meals, which really helps them not feel deprived, not feel hungry, and do well in the long run. Another hormone helps with blood sugar, and this is extremely important for diabetics. And that's why when we did gastric bypass in the 1960s, we found the next day diabetes was all of a sudden a lot better, and within a week, patients who'd been on insulin all of a sudden were miraculously cured of their diabetes, although we don't like the word cure, because it's an ongoing medical condition. And this now explains years later what was happening back then is through GLP-1, a very potent incretin, a hormone that works along with insulin, and it promotes insulin secretion, and obviously it helps with blood sugar. So you get a big bump in GLP-1 after both of these operations, which explains again how diabetes improves. Any questions about any of these so far? I hope it's not too technical, but...
Can you measure ghrelin or ghrelin? Can you measure any of this?
You mean right now, in our clinical practice? Not really. This is mostly from research studies.
So you can't even look and see like in someone's stomach or blood?
Well, you can, but you need to have a reason to do that. It's not part of a routine blood work. But yeah, for sure. I mean, people are always studying these things. Now, just to complete, there's another procedure called lap band gastric banding that tends to really not have much of a metabolic benefit. And that's one of the reasons we don't really talk too much about this operation, because it hasn't really succeeded in the way we, or some people had hoped it would. So when we do these operations, we expect obviously weight loss as the primary goal. And we see in individuals who understand that there needs to be a lifestyle change, a very long-term sustainable weight loss. And that number is about 60 to 80% of the excess weight. Depends a lot on how much effort a person puts in to exercise and adhere to the type of healthy eating style that's prescribed. And that number is obviously less for the lap band procedure. More importantly, patient's health improves. This is where it's truly magical, over 80% chance of getting rid of the metabolic syndrome, various components, very strong likelihood that they will be completely resolved or significantly improved with the metabolic procedures of sleeve gastrectomy and gastric bypass. Now the best evidence, the best study that's ever been done, and it's a very, very, very good study, was published 2012 and then 2014. The first paper was outcomes after 1 year, and then we got the 3-year outcome study. So I'm going to share with you that paper. What this trial was designed to do was to compare how diabetic patients or individuals responded to intense medical therapy, the best medicines that we know, versus gastric bypass or sleeve. So how did they do? 3 years later, if you just manage them with medications, in the beginning they may do better, but eventually they don't land far from where they began. These patients obviously had very high blood sugars and hemoglobin A1C levels, and it didn't really change much 3 years later. But the two groups that underwent surgery, sleeve gastrectomy and gastric bypass, significantly improved over 3 years. When they looked at their weight loss, obviously, no surprise, without any surgical intervention, not much weight loss, but both surgical patients ended up with body mass index of less than 30. Diabetes medications significantly again improved. Even when patients were on insulin, and about half of the patients in each of these groups began with taking insulin, but 3 years later, well, in the medical arm, the number actually increased, but in the surgical arm, significantly dropped. So that's where we are, 300,000 metabolic procedures or bariatric procedures in this country every year. And that is a significant increase if you go back to the years that I was in training. Here at Good Sam, we do roughly about 350 to 400 cases every year. And we are lucky to have Dana with us today. She's our bariatric coordinator and to a great extent responsible for our good outcomes. Just to show you what proportion of patients get what, this is 2013 data. Over 90% of the procedures are now sleeve gastrectomy. I think 2014 data is close, about 80-some percent, 85% plus. We offer this to patients who have a body mass index of at least 35, and obviously with prior attempts and desire to lose weight and motivation. We alter what patients eat. Individuals know that ahead of time, but the beauty of these procedures is that the appetite is suppressed, so there's not really a sense that they're being deprived. In the first month, we go to liquids only and puree food, but eventually meals are as appetizing as before. They're just smaller in quantity. There's definitely a trial and error process of learning what's ideal, and the focus is obviously healthy choices like protein and vegetables and avoiding carbohydrates and fat. With sleeve gastrectomy, and the reason a lot of people are really driven to it from the consumer, the patient standpoint, it comes down to it not interfering with absorption of nutrients. That's really probably the biggest selling point of the sleeve over gastric bypass. And so the requirements are a lot less for vitamin intake afterwards. But if you have a very motivated and compliant individual who's okay taking 2 to 5 or 6 pills, multivitamins or so every day, it tends to be less of an issue, yes.
Why B12?
So B12 requires a chemical called intrinsic factor, which is made by the stomach. So when we remove part of the stomach in the sleeve, there's just less of it. And in case of gastric bypass, we completely, skip it. So
PO or IM?
it's usually sublingual under the tongue, but it can be an injection form too. The pills work too, actually. So how safe are these operations? Well, they're actually no more dangerous than having a gallbladder removed. Mortality from a laparoscopic cholecystectomy removal of the gallbladder is about 0.1% today. And that's what we are seeing with bariatric surgery. So it's really a long ways from the 90s or years before, obviously, where we now see about a 20-fold increase in our safety of bariatric procedures. And that's thanks to a great extent to the systematic changes that we've implemented. It's not just one individual anymore performing this in a remote area. Back in the day, I think there were maybe a handful of individuals in every state or less doing bariatric surgery, but now we have over 250 bariatric surgeons in this state alone. So the systematic approach has been to create programs, create institutions that are certified to be bariatric centers of excellence, and we keep up with the standards that are recommended by various institutions, notably the American Society for Bariatric Surgery, and that ensures that everyone, the nurses, the doctors, the equipment, everything is as good as it can be. And again, be happy to take any questions. Yes.
Is there anything such as a set point? And if you lose weight, like say you go down 50 pounds or whatever, and you're just hungry all the time, and then you go back up 20 or 30 pounds, what the heck is that? Is there really a set point? Does the body have this resting?
So there's clearly evidence to support the metabolic set point. It's a newer concept, that's why I didn't include it here. But the thinking is, if you have had a significant weight gain in your adult life, you reset your metabolic set point, wherein your body gets very comfortable with that new normal.
Oh, great.
And then any attempt at losing weight, you tend to really, and the observations came from studies that looked at the amount of exercise individuals at a higher BMI needed to put in, and the amount of dieting and calorie restrictions that they needed to put in order to achieve the same weight loss compared to individuals who lived at a lower BMI. So that's really the thinking is, if you are heavier, you are at a disadvantage compared to someone who's leaner, and the same amount of exercise and dieting will simply not suffice. And we hear that all the time, patients saying that they spend 5 days in the gym, yet it doesn't really produce the effect that it used to produce way back when.
That's what's happening. So,
But aging is also part of that. So people always compare themselves to 10, 20 years ago. Well, you saw how rapidly BMR drops, right? So when you're a young teenager, you have a much higher resting state metabolic rate versus, as every decade goes on, our requirement goes down significantly.
so if you have a resting metabolic rate, just resting metabolic rate, can you increase that by weightlifting?
Good question. Yes. So that 65% of the energy that we use to just keep the lights on, you can actually change that. You can actually increase the amount of energy that your body will use even when you're sitting here. Most important element of that is the non-fat mass, or the lean mass. So weightlifting, like you said, is probably the strongest predictor of how you can increase your BMR. The other one, there are actually studies that show that individuals who actually have increased weight to begin with, they tend to affect their BMR. Okay, but that's not as important as the muscle weight. And then the hormones, thyroxine is another way that if you're low on, you affect your even basal metabolic rate. Some of the other hormones have been studied, but they don't seem to be as important as the thyroid hormones in altering the basal metabolic rate. The other component of that pie, obviously, is activities. That's where we can introduce exercise and hope to burn more calories. The genetics, it's not well understood. Some say it's only 5-10% of the story, and many of us think it's bigger, but that's obviously out of our control. Yes?
Yes, doctor. For a patient that is there to go to the hair care, it looks like for
Yes, Dana, do you want to answer
I
that?
think I have a question. I'm sorry.
So the patients who are planning to have bariatric surgery, what kind of support we provide them?
So we have 2 support groups here at Good Sam for a month that are free to anyone who's even considering surgery, and we have patients who come. Sometimes the process getting to surgery can take a few months, and so patients will come prior to surgery, and then they will often stay for several years after. And then I also offer a community-based group at Saratoga Community Center. And so we do have a pretty robust support program. We offer through our physical therapy department, they will do a special exercise program because many of our folks haven't done a whole lot of exercise, like Dr. Zare mentioned, because of joint issues and that kind of thing. So they have a discounted rate where the physical therapist will set up an exercise program to prevent injury. That's the biggest thing that we're concerned about with patients and people looking at.
Thank you. All right. Well, again, thank you for coming and being here. I know it was late and some had to drive through traffic. So.